Yeah, there's more people will trickle in.
Yeah. It's not awful.
It's pretty
Stated.
I was gonna say that last one.
All right, good morning, everyone. We're just gonna wait another minute for people to trickle in, and then we'll get started. Should we get going? Sounds good. All right, so let me introduce myself. I am Tim Olding. Question is, should we be looking online or looking in person? We'll look in person. I'm Tim Olding. I'm a medical physicist here at the Cancer Center of Southeastern Ontario. This morning, we're going to give you a tag team effort. Myself and our summer student, Harold John summer student, Kieran, and our medical physics resident, Fatine, will give you little pieces of some of the things that have been going on in medical physics over the last decade and 5 years, and then more recently as well. So, brief overview of where we're going to go this morning. I'm going to review some of the technology developments over the last decade, just as an interest piece. I did this last time medical physics presented here, just to remind people of some of the things that have changed under the hood. Then we're going to move on to highlighting some of the changes in radiation therapy over the last 5 years. And Fatine, myself, and Kieran will all discuss some of the recent medical physics developments and research projects. Okay, so since I've been at the Cancer Center, I've actually been through 6 generations of LINACs, linear accelerators. These are 5 of them. So starting on the left, you can see that it's got no arms. Well, it actually has one arm, the MV panel at the bottom. But we would treat these patients without an awful lot of imaging, just a bit. Moving on to the second one, we added imaging arms onto the unit, and we started doing KV images to set up the patients. Then you can see in the middle, by 2011, which is where I started coming on the scene, this was the first machine that I was helping commission, and we added our high dose rate beams into the mix so we could treat faster. And we also started porting devices on that I'll explain in a minute. By 2014, we had changed over to an entirely new design of linear accelerator called a true beam. And as of 2023, which is the bottom one, all of our units are now true beams. So they are all have particular capabilities. I'll talk about it in a second, but the last 2 units have matched high dose rate 10 triple F beams, and they have 6 DOF units, and I'm going to explain in a second what that is. So under the hood, it may not look like much, but we've gone from computers to most of our computer power actually being from servers and fast memory and integrated environments that have completely changed the way we operate. We are using an awful lot of computer resources. One could even say we're actually the biggest computer hog of the hospital. And a lot of this has to do with very non-exciting under the hood changeovers in electronics. Most recently, we're actually upgrading our storage array to a 42 terabyte array. Right now, it's a mix of 28 terabyte disks and solid state. It's going all solid state, which people will not know when it happens, but they'll say, hey, aren't things a little bit faster now? Behind the scenes on the LINAC, there's electronics we used to, and we had a sad moment where we retired the screwdriver, where we used to do all of our dose rate adjustments on a tiny little pot on a circuit board, making sure we got the right pot. And if that screw over time had a bit of slop in it, we'd sit there and go, okay, a little bit back, a little bit forward, a little bit back, a little bit forward. And now it's all on these field programmable gate arrays. There is a series of tungsten leaves that we actually deliver radiation through. And those series of tungsten leaves is called a multi-leaf collimator. They're thin leaves that travel in and out of the field as the beam is being delivered. That has completely changed under the hood. We now have a 10 millisecond refresh time on these updating the positions, which means we can deliver things faster, smoother, less wear and tear on the machine. If you're interested, I'll talk to you more about it later. A lot of the components have been switched over. We have resolvers everywhere, which allows us to get sub-millimeter precision on all of our positions. And to do it reliable, we used to use optical encoders where it would spin around and read the optical side of things. The carousel has been redesigned so that when we're delivering different energies of beams, it's a new process. It does mean this combined with this means that every time you deliver a beam, it runs through a whole series of checks, and therapists don't like that because it's a 30-second delay as it's making sure everything is perfectly right. Auxiliary systems like gating, where we actually gate the delivery, and this is a camera that senses the patient breathing motion and against a surrogate motion block. The imaging system, it's kind of hard to tell some of the times what image quality changes have been made, but we actually, I was part of commissioning a 10 times dose reduction algorithm. So we reduced the dose delivered by every cone beam to a patient by 10 times while maintaining the same beam quality. The couch, I don't know if you can see in the bottom corner, I've highlighted in red, but one of the initial ones that I talked to you about, our couch rotation was on the order of about 2 millimeter slop. That means as you rotate around, it would not hold a perfect, not hold a perfect circle. It would slop by about 2 millimeters. We're all the way down to about 0.7 millimeters, and all the rotations, they're anywhere between 0.1 and 0.2 millimeters for a massively heavy machine spinning around a patient. This allows us to precisely target where we are hitting things. The couch has now two programmable perpendicular rails where we're actually to not only rotate the patient, but we're actually to roll the couch and pitch the couch so that we can basically align the position of the patient perfectly with our planning CT in a 6-degree of freedom match. And so our tolerance on a daily is 0.5 degrees and a millimeter, but we can actually do better than that. That's just a check that everything's go. It doesn't yield to an exciting results. You'd have to really look at it to see the fine details of how the match are better, but the match is better. This is a day 9 on one of the older units and a day 10 on one of the newer units. Again, a day 6 on one of the older units. You can't tell subtly, but there is a clarity to some of the features that you're looking at that means that we can get better image matching on the patient. And lastly, before I head off into where are we going as a cancer center, there's 2 items I wanted to highlight. One is that how we deliver treatments is different. In 2007, 2008, there was a patent filed that has a way of delivering patient treatments continuously in an arc that I think we're all familiar with around the patient, but it allows us to sculpt the dose in a way that's almost as good as the previous IMRT that we were treating, but way more efficiently, so that patients spend less time on the bed, and that's hugely important because patients move. And so you can see the die-off of IMRT on the left-hand side in 2013, and how our number of IMRT treatment plans have steadily grown. You can see it's maybe starting to plateau a little bit, but I'm going to explain some of the details of where our patient population is going from a medical physicist perspective in the next few slides. Okay, lastly, in the last year or so, actually last year, May 2023, we introduced our first AI. Those of you who know me, I'm a little bit of a resistor to AI type items, but this one's actually a pretty decent one. I got convinced. So every patient gets custom contours, gets contours on them, segmented for well-known structures, average of 12 patient sets a day, typically taking about 3 to 4 minutes per image set. I asked the dosimetrist, is it working well? And they said, well, when it works, it's great. Some hiccups along the way, but the technology itself is really good. Okay, so this next part is going to be, I'm going to talk our way through a highlights reel of some of our higher volume sites. And then what I'm going to do is partway through, I'm going to pass off first to Fatine in one section to talk about what we're doing in one of the sites, and then next to Kieran in the next section to talk what we're doing in the next site. But what I tried to focus on is change in radiation therapy treatment over the last 5 years, just simply not as an RO perspective, but from a medical physics perspective. How is the flow of a patient through the treatment process been changing? And then some of the recent medical physics developments and research projects along the way that have enabled how we're changing our treatments. So over the last 5 years, we have a steady increase of between 2 to 2.5% unique patients being treated. That doesn't mean visited in the cancer center, but being treated by radiation therapy. So it is a slow, steady growth. It's been a little bit less over the last 2 years, but my anticipation is that 2% trend will probably continue from what we're seeing. I want to note that all the data coming up, this is my queries of our patient database. It's not the CCSEO official data. So if there's any mistakes there, blame me. Don't blame anyone else. So breaking it down. So on the top is the linear accelerator. On the bottom is the orthovoltage and brachy. Orthovoltage and brachytherapy, I'm not going to explain them, but they're okay. There will be a couple of slides later. I got a reaction from the audience that will talk about it. But more or less, they've been stable. They haven't really changed in their growth pattern right now. There is a little bit of an uptick in orthovoltage right now, post-pandemic, and I think that's a combination of word of mouth on certain treatments and just simply people accessing that resource. I'm not going to talk too much more about that, but on the linear accelerator, you can see a steady number of unique patients growing, top orange line year over year. And let me just explain, we have 2 types of planning workflows. One of them is where it goes through what we call the dosimetry resource, where the patient plan is optimized. And the other workflow is that where it goes through planning, and they are simple, well understood plans that are delivering typically a palliative dose to a patient. And what we're seeing is a steady increase in the demand on the dosimetry plan resource. Now, you may be asking, why on earth are you presenting just a number of plans? And we've switched over recently in how we code our data to CCSEO, and we do have RT protocols that are now in place in the data, but we've only been doing this for the last 2 years, and last year was our first submission date. So it's easier for me to compare the last 5 years just against number of PANs, number of unique patients. So the question with increasing number of patients is, are we going to run into a machine capacity issue, or are we going to run into an RT staffing issue, or both? You'll notice in the green line that the number of patient plans is actually going down. I'm going to explain why that is, or more or less what that is in the next coming slides. But the demand on the RT staff in terms of just simply the number of patients that they're managing is increasing. So we have a staffing issue, not in terms of machine time, but in terms of demand on the overall staff, all the way from ROs through to the RTs delivering the treatment and all the supportive services alongside of it. Yeah, I think I'll leave it there. Okay, so let's get on to the first site. What are we doing on time here? 8:23, we're fine. Okay. So brain, So what this hieroglyphics on the side means is brain means that it's coded as the body region we're treating, combined with a CNS diagnosis. So when this means body region we're treating minus diagnosis, that means that it is not a CNS diagnosis that we're treating there. So not much has changed in primary CNS diagnosis. Apologies to ROs if I'm saying this wrong. Over the last 5 years, except in 2020. And that was when surgery shut down. I suspect that's probably what that spike in the number of RT treatments is. Don't quote me on it. I haven't gone patient by patient through it, but I think that's where it's probably coming. But you can see that there's a steady increase in demand in what we call FSRT, which I'll explain in just 1 second. What that means. SRS, we don't have a high volume. We are still referring to other centers for SRS, but today I hope I'll talk to you a little bit about maybe we should be bringing this back into our cancer center. Okay, FSRT, so tiny brain lesions, usually multiple ones that we're treating. We introduced this a while ago, so I don't really have anything particularly new to present on this in terms of medical physics involvement. But in 2019, what we did is through some work by one of our physicists and a physics resident, analyzed all the matching capabilities of our FSRT patients' MR to CT, because MR is where we derive our tumor contours from, and determined that our best efforts were about 1 millimeter uncertainty in the match. That combined with the VMAT technique that was developed, combined with the 6-DOF match on the couch, so we're tilting them, combined with what we know about the tightness of our radiation isocenter, combined with what our uncertainties are for small field dosimetry, led us to ask the question, can we actually treat brain FSRT with 2 millimeter margins as opposed to 5, which is what we were doing at the time? And I've showed this work before, but one of our PhD students developed a phantom, blinded that as realistic a human shape as possible, doping the skull region with a contrast enhancing bone-like material, and then did a representative multi-target plan where you would have to do pitch and roll, and then they had the staff run the phantom through the process, and in the end, after I'm skipping all the boring physics stuff, but in the end, if you look at the slide on the right, a combined criteria that we use called gamma, which is a 3% 1 millimeter. It means if you look within 1 millimeter, will the dose be within 3% of what the plan predicted? And we're getting really good agreement, which means that yes, we can use 2 millimeter margins with all those combined uncertainties and deliver it. Can we use less than 2 millimeter margins? That's the question that's being asked. Well, yes, but you will have uncertainty in your delivery and the overall thing. Okay, so that's FSRT. We have a challenge ahead of us because we actually use an algorithm for FSRT that is really fantastic and is being retired in this version. So we've been working for a little while on the medical physics end of, can we actually produce the same quality or better quality FSRT plans once we move from this version of radiation therapy environment, version 15, to version 18. And initially we were thinking, oh no, we are in trouble. But there is what we did with the last Linac purchases, we purchased HyperArc, which I'm not going to say anything about because Fatine is going to now come up. But the question that Fatine is going to try and answer is, would variant HyperArc be useful at cancer center? All right, Fatine, time to step in. How am I doing? 8:30? That is. Oh, sorry, do you want me to step? Sorry.
22.
I'm at 8:22. And sorry, I'm used to a Mac. And it's this one. Present mode. Yep.
We'll just double check. Yeah, perfect.
Take it away, Patty.
Thanks, Kim.
Good morning, everyone. My name is Fatin Bashrat. I'm a medical physics resident at Cancer Center of Southeastern Ontario. Today, I will talk about introducing hyperarc technique for fractionated stereotactic radiation therapy at our cancer center. So in this presentation, I will briefly first introduce the hyperarc FSRT treatment, the advantages of hyperarc over our rapid arc VMAT FSRT, and then I will move on to the planning of hyperarc treatment, and we'll talk a little bit about the specific immobilization device that is required for the treatment planning and delivery. Also, I will discuss the results of our preliminary investigation on comparison between the dosimetric parameters between the hyperarc and rapid arc FSRT plans. So variant hyperarc stereotactic treatment is a new to us LINAC-based BMAT technique for brain FSRT. It is a single isocentric technique which uses non-coplanar arcs, which can provide highly conformal plans for single and multiple brain targets. The arc setup for hyperarc treatment is based on a fixed geometry. So with the hyperarc plans, there are 4 available arcs that comes with the plan. I will talk briefly about details about the available arcs and the couch rotation in my upcoming slides. The main feature about hyperarc is the automated treatment delivery and treatment planning option, which in turn will shorten the overall treatment time. So as I mentioned, the main feature of hyperarc is the automation. So in terms of the treatment planning, hyperarc can locate the treatment isocenter automatically at the center of the selected targets, center of mass of the selected targets. Also, there is an option for automatically optimize the collimator angle rotation. And in terms of the treatment delivery, hyperarc comes into play here. It eliminates the need for the radiation therapist to go inside the treatment room and place the patient manually to deliver the non-coplanar arcs. So for planning of the hyperarc treatment, it uses a specific normal tissue objective, which is called the stereotactic radiosurgery NTO, or in short, SRS NTO. So this SRS NTO controls the dose fall off and the dose bridging between the nearby targets, which in turn will produce a plan that will generate a highly conformal dose to target while sparing normal tissues and the important OARs. So in terms of the patient safety, hyperarc treatment technique provides a collision check when you are planning the hyperarc treatment. So this collision check provides a check to prevent any possible collision between the patient gantry or couch gantry collision. So there is a predefined patient protection zone in hyperarc treatment. In terms of the treatment planning, this patient protection zone is defined as the allowed limit for the placement of the isocenter. So if the isocenter of the treatment is within the patient protection zone, then we can consider the delivery of the hyperarc treatment, the automated delivery of the hyperarc treatment will be collision-free. Now, in terms of the treatment delivery unit, the patient protection zone is defined as the allowed limit for the couch position. Now, there is also another option is available during the planning of the treatment, which is called the virtual dry run. A screenshot of the virtual dry run environment is shown on the left. So this virtual dry run is a 3D animation of the delivery of the treatment that you can visualize and make sure that the automated delivery is going to be collision-free. So in terms of the patient immobilization device, for the treatment of the treatment planning and delivery of the HyperArc plans, there's a specific immobilization device that needs to be used, and it is called the Cube Fix and Compass immobilization device, which consists of a couch insert and a thermoplastic mask that sits on the top, on the raised component of the couch insert. And it is recommended by the vendor that we should scan the patient from shoulder to the top of the Encompass immobilization device to make sure that the entire anatomy is captured during the CT sim. So now let's look at the available arcs that comes with the HyperArc plan. So there are 4 arcs available, 1 coplanar full arc and 3 non-coplanar half arc. On the table shown on the left, the arc type and the rotation of the couch is presented. As I mentioned, there is an option for the automatic placement of the ISO center. Also there, if it's necessary, we can manually place the ISO center, but in that case, we have to make sure that the ISO center is within the patient protection zone if we want to deliver the entire treatment plan, including the planning and the delivery automatically. So now let's move on to the results of our analysis. So for the comparison between the RapidArc and HyperArc FSRT plan, we selected 5 previously treated plans that these plans were treated with RapidArc FSRT. So we took this plan and replanned with HyperArc technique. For both of the plans, the beam energy was 6 MV photon beam, and we tried to keep the couch rotation identical between the 2 plans. So on the left table, the cases and their associated prescription dose and the number of targets are listed. So our maximum number of target for the analysis was 10 and the minimum was 2. So this table summarizes our main results. I know there is a lot going on in this table, but we are now we'll focus on the number of monitor units that is allocated to the non-coplanar arcs. So if we look at the highlighted columns, we can see that in HyperArc plans, it allocates more monitor units to the non-coplanar arcs compared to the RapidArc plan. So this feature of HyperArc leads to more spherical conformal dose distribution compared to the RapidArc plan. Now, if we compare the volume of the brain that is receiving 30% of the prescription dose and compare that with the RapidArc plan, we can see, if we look at these 2 highlighted columns, the HyperArc plans can generate that 30%, the volume receiving 30% of the prescription dose, way less compared to the RapidArc plan. So there is a significant decrease of the volume receiving 30% of the prescription dose with HyperArc plan. So now let's move on to the comparison of the OAR dose. So in this DVH, the OAR dose for RapidArc and HyperArc plans are presented. We are not going to go through the Dmax for each OARs. There's a lot going on. So in summary, both of the plans, RapidArc and HyperArc FSRT plans, meets the CCSEO FSRT OAR dose criteria. But our analysis also shows that HyperArc plans provided 10 to 20% lower dose to the OARs compared to the RapidArc FSRT plans. So this slide shows a visual representation of the low dose pillage. So if we look at the actual view of the RapidArc and HyperArc case, we can see that the volume receiving 30% of the prescription dose is way less, and the isodose distribution is more conformal in hyperarc plan. We also compared the conformality index between the two plans. The volume of the brain receiving 100% of the prescription dose is shown, the actual view is shown on the left. And on the right figure, we can see the comparison between the conformality index for different patients and the corresponding targets. So in summary, our analysis showed that the conformality index is pretty much similar for the rapid arc and hyperarc plan. There is not any significant difference between the conformality index has been found in our analysis so far. So now let's move on from FSRT to SRS. There has been a lot of study on investigating the feasibility of hyperarc technique for the stereotactic radiation surgery. So one of the report is by Ho and colleagues. They compared the hyperarc plans with the CyberKnife SRS treatment plans. And their report suggests that hyperarc SRS treatment can result better dose distribution parameters compared to the CyberKnife SRS plans. However, their study was based on HDMLC. In our cancer center, we do not have the HDMLC available at this moment. So in our center, we have Millennium MLC. Now the question is, would Millennium MLC be able to generate clinically acceptable hyperarc SRS plan? To answer this question, let's look at another study by O'Hara and colleagues. They compared some dosimetric parameters between the HDMLC and Millennium MLC hyperarc plans. And their study reported that for a small target, which is less than 1 cc, if we compare the plans generated with HDMLC and Millennium MLC, the conformality index and the volume receiving 50% of the prescription dose will be higher. The conformality index will be higher for HDMLC, and the volume receiving 50% of the dose will be lower for HDMLC generated hyperarc plans, but the homogeneity index and monitor units were comparable between the two plans. So what is the take-home message from this analysis is Millennium MLC has the potential to generate acceptable hyperarc SRS plans for target with size of greater than 1 cc in volume. So in summary, the hyperarc FSRT plans provides automated treatment planning and delivery, and can generate highly conformal plans with highly conformal dose to target and lower low dose pillage. And there is an option during treatment planning to the delivery, and from treatment planning, we have the option to check the patient's safety as well as during the delivery of the automated hyperarc plan. So in summary, the single isocentric hyperarc technique can be a useful method for the brain metastasis treatment in our cancer center. Thank you.
Thanks, Fatin. What did I do? I just have to put it on screen share mode. All right. So there's the question, the answer. And moving on to breast. So, yeah, I'll leave any questions you have about hyperarc to the end. Breast is one of our highest volume treatment sites at the Cancer Center. You can see from the top row in orange, that's with breast cancer body region treated and diagnosis, that we have a steady 10% year-over-year increase in the number of treatment plans for breast, which probably is roughly translated to 10% increase in the number of unique patients that are being treated. There's a steady growth. There is, interestingly though, if you move to that middle section, there is a significant drop in the number of treatment fractions due to the tendency towards hyperfractionation. By hyperfractionation, I mean less treatments with higher dose. So you can see the two gray fractions in the middle of that table. They've been pretty low for a while, and they're dropping more and more. The big change in the number of treatment fractions that we're getting is actually with what's called based on the fast forward trial criteria, 26 gray and 5 fractions. In the last 3 years, the uptick has been enormous. So these patients who were previously coming for 16 treatments are now coming for 5. You can imagine that means that the patient management issues haven't changed. Still seeing more patients, that's a problem, but the machine capacity is less of an issue. And of course, there's increased demand on dosimetry and RO resources with an interest in saving time anywhere we can. So how can we make our workflow more efficient? How can we make less changes? How does our policy make so that we are not wasting time doing things that we shouldn't be doing? Sorry, did I miss anything? Oh, sorry. The last column there is brachy patients. It's in orange. You can see it's been steadily dropping off for breast brachy. That's primarily due to the fast forward option being available to us. Before, the breast brachytherapy used to be done in a single week with 7 fractions. And when the patient gets the opportunity to have 5 fractions of treatment versus 7, and not have the challenge of breast brachytherapy, they tend towards choosing the fast forward approach. But I will show you what we're doing in that area so that you can see that we are making changes as well in our brachytherapy process. Okay, so how do we save time? Well, re-enter Limbus. I asked the dosimetrist to make sure, because sometimes you think from a physics end of things, oh, that should save you time. And then you ask them, does that actually save you time? And they go, oh. But in this case, they said, no, it actually does save us time when we get auto-contoured structures for the breast brachytherapy. It helps. And with such a high volume site, every little bit helps. Now I'm going to pass off to Kieran to talk about the summer project and ask the question, can another thing help? Can we use Eclipse scripting to meaningfully save time in breast planning? And Kieran will show you what his role was in there. Let me. You can probably do this faster than I can. And then.
Perfect. Yeah. So thank you so much for joining me. My name is Kieran Balaso. I'm excited to be here to talk about the AutoFF tool that I've been working on over the past 4 months, and it's been in development for the past couple of years with Dr. Decker. Yeah. So the main focus of this tool and this project has been really on breast field and field plans, which essentially consist of a medial and lateral field, applying a dosage to the breast tissue. Now, what makes these plans interesting is with these 2 fields, we actually introduce additional subfields, which change the positions of the MLCs to cover different parts of the breast tissue and really distribute a uniform dosage across the entire breast. Now, while this is a unique process for every individual patient, it's a very algorithmic process which can actually introduce automation. So the goal of my project was essentially to integrate an existing algorithm that we had to create these subfields into the Eclipse system using the ESA API. We then wanted to test this overall program just to make sure that the actual program was doing what we wanted it to and got the results that we expected. And then we also updated it a bit just to include additional verification steps to make sure it was as efficient as possible. So with that, the way this tool works is essentially we start with somebody developing the medial and lateral fields where they already established these in Eclipse. They then run AutoFF, and it's just the click of a button, and that's all you need to do. And it generates the subfields for the dosimetrist or medical physicist or whoever's essentially developing these fields to help speed up that process. The dosimetrist and then medical physicist or whoever's in charge of reviewing these plans is able to do that after and adjust it accordingly. But it mainly just speeds up the process and helps, facilitate the entire process of generating these subfields. So some of the challenges we faced previously were essentially we had the algorithm already developed. We actually had to export it and then re-import it in. I apologize for the large text, but something might have happened. But yeah, so essentially we had to export it and then re-import it in. Additionally, Eclipse used C#, which isn't ideal for actual medical imaging technology and doesn't have up-to-date libraries like MATLAB. And then additionally, the algorithm previously allowed for redundant fields, which essentially lowered the efficiency of the program and made it less effective at actually producing subfields. So with that, the way this program or algorithm actually works is it starts off by importing the data into Eclipse. And then from Eclipse, it's able to import that into MATLAB, where we're able to use a bunch of tools for medical imaging in there to actually determine what the MLC positions are. It then passes that back to the ES API or C# code, and that spits it back into Eclipse, which from there, the dosimetrist or whoever's in charge of handling the data there is able to. So with that, actually setting up the plan is very simple. All you need to do is set the initial lateral and medial fields, set the dose calculation model, and make sure that the correct machine is selected. It's very trivial stuff that you just need to essentially set up beforehand. And then for actually running the algorithm, it's very simple. All you have to do is go up to the tools and then run the actual plugin. It's one button, that's it. For me, I was even lazier and I just changed it so it's Control-R and it's one hotkey. And it generates essentially all the subfields. And I thought we'd go through a test example just to show, well, actually, sorry, I should explain how the algorithm works first. Essentially what it does is it takes the isodose levels inside the breast tissue and maps them over to a beam's eye view and gradually covers the breast tissue depending on where the dosage is. Now it does this and then adds additional verification steps to make sure none of the two fields are very similar or that any of the fields consist of the MLC positions covering the entire breast. From there, it just spits them back to the C# code, which sends them to Eclipse and generates it for the dosimetrist or whoever's in charge of actually generating these fields. So with the final output of the actual tool, as you can see on this left-hand side, all you had to do is click the one button and it generates all of these subfields for you. And you can see a preview of one of the subfields on the top right. And yet with that, I thought we'd go through just a quick example just to kind of showcase how this tool actually works and how simple it is to use. So essentially, we start off here with the medial and lateral fields on the breast field and field plan. And essentially, you can see here that on the anterior side of the right breast, we actually have an increased hotspot with 118.2% maximum isodose. So here's a close-up view of that same image, and you can just see that there's not a uniform dose spread across this tissue at this current moment of the plan. And usually what would happen here is the dosimetrist would go through and change the MLC positions of all the subfields so that they would get a more uniform dose. And this could take, minutes to hours, depending on how long or how complicated the plan is. From there, what they can do now instead is actually run AutoFF, which is the tool we've been generating, and it generates these subfields. And usually it generates 3 to 5 subfields. Here I showcase 3 lateral fields and 3 medial fields that it's able to actually create. And as you can see, the MLC positions change and gradually cover more of the breast tissue as the subfield increases. So with that, I wanted to showcase this example because sometimes the algorithm doesn't always work, or sometimes we don't have a uniform distribution right off the bat between the 2 open fields. So in this case, as you can see, there's it favors the left side of the right breast, and actually has a hotspot there, which isn't ideal, but this is kind of that last step of the tool use where essentially a dosimetrist or medical physicist still has to review it just to abide by the protocol that we do have set with KHSC and Cancer Center. But with that, here's a close-up view of that, and you can still see that same hotspot on the right breast, left side of the right breast, sorry. Yeah, so with that, all they would have to do is change a couple additional MLC positions, or they can remove subfields, which I'll showcase on the next slide. But it's a very simple process to do this, and they would have had to do it anyways with the original generating the fields without the tool. But in this case, we actually adjust the subfields. We just remove 2 of them, and we get a much more uniform dosage, which essentially stepped down from a maximum dosage of 111.2% to 104.9%, which is a significant decrease. So after that, we just kind of showcase here some of the final adjustments and some of the, how it's a more uniform distribution. Do take into account that the heat map is actually a different scale than previous slides. This one only goes up to 104.9%, but it's a much more even distribution, which is a significant finding. Lastly, I just wanted to showcase another example that actually worked right off the bat. And this was a very common case where essentially we had the initial field set up. So they gave an even distribution, and once after actually running AutoFF, it significantly lowered the maximum isodose level, and essentially we're left with a more uniform dose. So what's kind of left after this project is essentially we have some files to help integrate it and troubleshoot anything. Additionally, Dr. Decker is also here in case there's any issues or anything that we run into in terms of problems. And then some of the next steps for this is, oh, sorry, I think we made that. Oh, no. So yeah, some of the next steps of this program is to actually make a post-AutoFF adjustment algorithm that makes those final changes that we talked about within the test case. And then also implement this on the clinical server so it can be easily used by dosimetrists and medical physicists. And then the last thing is adjust it so we can set different parameters for how we want to declare a redundant field within the. So before I conclude my presentation, I would just like to acknowledge all the contributions made by Dr. Kerr and Dr. Decker, who have been very supportive in this project, but also extend my gratitude to the rest of the medical physics department who have also been very supportive in this project. But other than that, yeah, feel free to reach me at this email if you have any questions about this, and I'll hand it back to Dr. Olden.
Thanks, Kieran. So 2 things to highlight. First of all, the ease of getting something into a clinical working environment like Eclipse it's not easy. And so Kieran did a fantastic job in that. And the interesting thing about this is while the RO and the dosimetrist will still, of course, have to do the work of deciding where those fields are going to be, it's possible that we now may have a tool to help them along to speed time in some of the part of the planning process. All right, so let me go back, and I think we're okay, but might have to give you a highlights reel of the highlights reel. We have about 10 minutes, and I think we're almost done. Okay, so one more thing on breast brachytherapy. So one of our other projects that we've been working on for some time is oh, sorry, I'm getting ahead of myself. We haven't made many changes since 2021 when we aligned a little more with the ABS-JAK-ESTRO criteria, and just to make sure we were completely aligned with that. In 2023, we moved to a 3-fraction treatment. So it's treated and then they're done by midweek. And in order to accommodate that, we had to work through a process and basically put more needles in at a tighter spacing. But there is ongoing interest in this treatment. Some people really do enjoy the advantages of the breast brachytherapy process. I am not the RO who's qualified to speak to that, so I will not say anything further about it, but it's certainly an interesting challenge to plan. All right, so we've had an ongoing study where we've been using EM tracking along with the Department of Computing to aid in our providing checks of our tracking of the catheters that we insert. So it'll basically, the physicist will track the catheters, but we will use this EM probe going in and out of the, in and out of the patient catheters to check the goodness of the physicist's tracking, and also using some ultrasound guidance to try and see if we can guide the process. We use CT right now, works well, but ultrasound could also reduce a bit of patient dose. The long and short of that is it's finding a catheter tip is rather challenging, and they've been working on finding the catheter tip, and we're getting there. It's not quite ready for prime time, but it's ongoing. Okay, moving quickly along through the last three that I'm going to highlight. Colorectal. So body region and diagnosis. The number of overall dosimetry plans or total plans has actually been dropping, but that's primarily because of one significant reason. I don't think it's about the patients, the number of patients, although there might be some slight change in the number of patients per year, but it's primarily due to the fact that there was a change in practice. And in 2022, we went from 2-phase plans, which were 1.8 to 2 gray per fraction, but usually 1.8 gray per fraction, 25 treatments, plus the second phase, whatever it was, 5 to 9 treatments, to single phase short course, which is more or less taking over. That means our number of plans is dropping rapidly. Number of treatment fractions this past year was down by 45%. Machine time goes up, doesn't mean patient management time has changed. Prostate. Prostate isn't ever ongoing changing field of practice. Overall, we might have a slight uptick in the number of prostate patients being treated with RT. I'm not entirely sure. Our brachy population is fairly steady, that we get prostate brachy patients through. The story again is a steady growth in hyperfractionation and corresponding decrease in standard fractionation. Hyperfractionation SIB treatments. SIB means simultaneously integrated boost, where we would take a phase 1 where we treat a larger nodal region plus the TART plus the main site, and a phase 2 where we would just treat a boost to a particular site, put them all in one treatment plan. When the data was mature enough, this center moved towards SIB treatments. Both of them free up machine time. And in 2023, we introduced prostate SBRT. Based on the skills that we had available at the cancer center, we could do that. Now combined with the machine capability. So on the left, an SIB treatment. On the right, an ultrasound guided implant of the gold seeds that you use for a prostate SABR treatment, and then of course the treatment down below. The main physics work in this was just simply providing the planning technique or developing the planning technique so that we could do these kinds of treatments. Along the way, of course, all of our machine checks, ISO center checks, and all that sort of things factor in, but that's something we're already doing. We also have an ongoing project with prostate brachytherapy. It's very similar to breast brachytherapy. Can we it's a real-time planning where we're basically finish the plan and treat. It would be comforting to have a second check using EM tracking of the overall patient plan. The challenge once again is, especially as you get close to the bladder, those tips disappear on your prostate catheter on ultrasound. They're hard to see. We have been working with computing again on this. One of the things we've been trying to do is develop a predictive model. So we deep learn our prostate data and develop a predictive model for the tip end. We use a measurement that we already have and say, okay, let's fill in the details on where this catheter is going. The problem is if it's bending, fortunately it's not bending that much, but if it's bending, we could be off. And that's what this is showing, and we have published results on that. Lung, and I think this is the last one. Lung has not changed that much. The number of treatment plans you can see has been steadily going down. The interesting thing is the number of simple plans and simple plans being without optimization through the dosimetry resource has been dropping. So the amount of dosimetry plans has been going up, which is more workload. one of the things we did recently, just to save a little bit of efficiency just on the machine, although we don't really need it on the machine time, is to flip over to delivering with our 10 triple F beam, all lung high dose treatments. The conformality index, sorry, I went ahead a slide. This is what we did when we went to VMAT SBRT way back in 2014. We improved our plans and our delivery efficiency. This is where I was now talking about, where the 10 triple F actually produces a marginally more conformal plan with less mid-dose spillage, and it's faster delivery, which means these lung patients who don't breathe well, who move when they're not breathing well, will get their delivery faster. And so it's an intangible thing, but I think they're getting better quality treatments. Okay, and as I'm wrapping up, oh, we're at 2 minutes left. Okay. Interestingly, I went to dive into our vert sim, so simple plans, because last year we dropped off by 250 simple plans from the year before, and they were mainly in GU and lung. And from my anecdotal talking with people, I think there might be a change of practice going on here with the immunotherapy, that we're giving a longer runway for some of these patients without radiation. I don't know if that means they're going to come to us eventually or not, but that is a definite interesting change of practice. And I'm going to skip what we're looking at in body SBRT, and I'm going to leave you with a couple of my thoughts. So in 2000 so books in our home used to be about 70 books a week from the library. In 70 books, out 70 books, kids' books are tiny. As late as 2019, that was my daughter's haul from the library. She reads over 100 books a year, and you can see the chart that she filled out during the early pandemic when she was even more bored. Not 6 months later, that was our shelf. No more books, because everything was virtual and the iPads were all plugged in because they were all reading on their iPads. Some part of me fought it because I like a paper book. I'm now reading on my iPad. So the question is, in our cancer center, we have most of our main issues, from what I can tell right now, are efficient workflow and standardizing practice against our different biases. My question for us is, from a medical physicist end of things, are we willing to change and without compromising high quality treatments to get better workflow of patients through this cancer center? The second thing is that change can happen for different reasons. You can see my single reflex SLR on the left. You can see the fact that I upgraded to a digital when the time came right to do so, and you can see our flip cell phone. And then, what do you think we took on our trip to BC in 2021 in the middle of the pandemic? We took our phone, because it does more or less everything you need to do. And I'm not a photo expert, so I can't tell the difference between the quality of those photos. So change can happen for a lot of different reasons. Is it a higher quality picture of camera? Well, some people might argue that it is. I don't think it is, because the optics are not quite the same. But we have to look at, why are we doing things in balancing a bunch of different parameters? And I'm sorry, I've gone a minute over. So I haven't left any time for questions, but there you go. If you have time for one quick question, that's fine, but I understand you guys move on.
I don't have a question.
Yeah.
I just want to thank you for this presentation, and also acknowledge actually the great work done by physics, symmetry, and radiation therapy. I mean, it's not just advanced technology, it really translates into much better outcomes. I remember the days when we would ask for a VMAT plan, or this sounds too complicated for some who may not be in the field. It is actually complicated, but and then we would be told, this is really too much work. Now it's the reverse. Like, if you ask for a simple plan, it may not really sit well, because of all the advancements and improvements that you have helped us accomplish. So despite your, maybe doubt of AI, but I think actually I would challenge you on that. I think AI has a lot to do and offer, and I think if you continue your research and what you're doing, we'll get even more. So thank you.
All right, thank you very much. All right, have a great day, everyone.